Good morning. Let's get started with Grand Rounds. This morning it's our pleasure to have Dr. Lori Pounds here, who is an assistant professor in the Department of Surgery in the Division of Vascular Surgery. And this morning she's going to be telling us about some new treatments for venous disease. Dr. Pounds told me that she hails from Pittsburgh. She did her undergraduate at the University of Pittsburgh, then medical school at Temple in Philadelphia, did her general surgery residency at Galveston, then back to Temple for her vascular fellowship, then back to Galveston for her first faculty appointment. Was there on the faculty for 5 years? Six? And then Katrina came along, kind of destroyed things, and she joined the Peripheral Vascular Associates here in San Antonio, but realized that she missed working with residents. Imagine that. We need a CT scan to find out exactly where the lesion is. We all have it, though. Yes. And she's been on the faculty now for 1.5 years, and it's a pleasure. Welcome, Dr. Pounds.
All right, I'll try to keep this interesting and keep everyone awake. Thank you for the nice introduction there. The VA was gracious enough to let me out for a little bit today. I'm a Monday morning first start, so that's usually why I don't make it over here. I can't seem to coordinate both of those and be on time. Part of when I went to fellowship, the gentleman that I worked with was a guy named Tony Comarota, who is fairly large in the venous world. And I have to admit that during my fellowship, I was rather tiffed when we did some venous reconstruction, and in the other room there was like an aorta or a carotid, and I couldn't believe that I had to survive a venous case to, miss something that was so juicy and good. And so I vowed to never do any kind of venous work again, just like most vascular surgeons. Then I went to my first job, and there was 3 of us fighting over all those juicy aortas. And someone who was in charge, who would go, aorta for me, vein for the other 2 people. He'd give himself a carotid, then a vein, then an access. And so I kind of just got used to what I was getting at that time. And then also I ended up, I had 2 children, and I found that standing for a 5 to 7 hour aortic case was rather challenging. And so I sort of started adopting this love for venous disease. When I went into private practice, it was very easy to love venous disease because it pays quite well. It takes about 30 minutes to do. And so I've sort of started branching out, and as I've done it more, I've started to really learn to love it and understand it and have a much better appreciation. And really there's a lot of missed opportunity, and for patients that we could really affect their outcome way more than arterial patients. Quite frankly, arterial patients, it's a cancer. They die in 5 years. They might be grateful you saved their leg. About 500,000 people. That's 1 to 2% of the adult population. Okay? That's an awful lot of people that are walking around with this. And I can tell you, since I've gone over to the VA in the last year, when I first got there, nobody was really that particularly interested, surprise, surprise, in venous disease. And so they were just sort of stuck welling in these wound care places, or just put an Unna Boot on it, or doing nothing. And so, I immediately said, what do you mean? I take all those patients in my clinic and opened up the floodgates. And after an entire year, I'm still doing 2 to 4 venous ablations a day in veterans with advanced venous disease. And so it's that common, it needs to be addressed. And if you look at symptomatic vascular disease, and it's funny because everybody has a little ribbon, right? They have a run, they have a walk, they have a little thing that's out there like, woohoo, look at me, I'm important. But if you look at venous disease in comparison with other things out there, coronary heart disease, peripheral arterial disease, congestive heart failure, all these have like complete centers dedicated to them. But if you look at how many places have like a vein center, or a vein center that is dedicated to treating advanced venous disease as opposed to cash for sclerovenous disease, there's not that many. And so if you really, really were a smart administrator, you would look and see that venous disease is much more common and that if you really wanted to make money or have a lot of people come see you, you could do like a venous and lymphatic disorders center, which is what I want. All right, so definitions: acute venous disease. We're going to talk about deep venous thrombosis, superficial venous thrombosis, or phlebitis as it's called. And a lot of these have some really just garbage generic terms that makes it very hard to sort of talk about it, to sort of compare apples to apples, and talk about different treatments, whether they're effective or not. But for chronic venous disease, people will call it venous insufficiency, varicose veins, spider veins, which we never, ever, ever say. You can call it telangiectatic or reticular veins, but any insurance company sees spider veins anywhere on any note. Even you can talk about the, venous ulcer that's engulfing their entire pretibial and medial malleolar area. They're like, ooh, cosmetic, and they'll deny it. So we try to stay away from the word spider veins. There's the Post-Thrombotic Syndrome, the Post-Thrombotic Syndrome. So there's a lot of sort of garbage terms that get lumped into one, which are really chronic venous disease. Sometimes you may not figure out why it happened, but you know it's there. So the end result is a patient has an ulcer. It can be a spectrum of disease from different origins that can result in the same clinical picture. And most of the time, I never figure out why they have it. They may say, oh, I was in a car wreck in the 60s, and I was in bed for 4 months with a broken pelvis. And I'll say, did you have a DVT? Nope. But then they have chronic venous disease, and so I sort of have to extrapolate that they probably did have a DVT at that time, but it was undiagnosed. All right, so let's talk a little about acute venous disease. If you think about it, this is a patient, actually pretty recently, who did this with me at St. Luke's? I can't remember now. It was very interesting. It was a gentleman who was mentally retarded who'd won the lottery. Bad family dynamics. But he came in with a septic and went into renal failure and actually ultimately died. About 3 or 4 days into it, after he was intubated, they noticed that he had this little purple area. Why does this thing not work? In the middle of his thigh. And that actually, you can see this area, this darkness going down here. That was the saphenous vein that was septic and had pus coming out of it. And we had to take care of that. And then DVT. I think you guys probably ad nauseum get a lot of talk about DVT and what's going on with that. The SCIP in particular, I will highlight here the prevention by using the DVT prophylaxis within 24 hours. Pretty much anybody and everybody really satisfies criteria to get something, some chemical prophylaxis as well as a mechanical, which is the SCD and TEDS, unless you document in your note why they're not having it. Just a reminder. All right, and if you look at chronic disease, that's also a spectrum as well. So this is the classic sort of little cash-paying patient that comes in and it's unsightly in their shorts, or it's South Texas where everyone wears shorts all year long. You have that. You can come up to varicose veins, which we'll usually describe as 4 to 7, 7 to 10, or greater than 10, and they'll be in clusters down the leg. You can have a phlebitis, which is an inflammatory, again, they can go on to some chronic changes. You can see the darkening in through there that will stay after the phlebitis is sort of healed, the inflammation. The lipodermatosclerotic skin changes, a little darkness in there, coming around here, which is called corona phlegmasia, which is a crown, or it's also called an ankle flare. And then really dark lipodermatosclerosis around the pretibial and ankle area here, and then clear up to venous ulceration. All right, so it's a very wide spectrum of how the patient may present. A brief review of the anatomy. About 10 years ago, there was a big international consensus conference, and just to be aware, so you can sound intelligent and not say things like prostrate, your sense of prostate. The superficial femoral vein was renamed. It is no longer the superficial femoral vein, or SFV. It is the femoral vein. So if you want to sound intelligent, you'll say they have a clot in their femoral vein and common femoral vein. So that's how you differentiate between the two, and then, of course, the profunda, or the deep femoral vein. All right, so it's a system of deep veins next to the arteries, more superficial vein system here, and then a collection of perforators which connect the two. So I always tell patients it's like I-10, you've got your frontage road, and then your on-ramps, okay? Going down and through here, the posterior tibial perforators used to be known as the Cockett perforators. And it's funny, you'll still see even our lab has listings where we still say SFV and coca perforators and whatnot. The other big thing here is it's no longer the greater saphenous vein, it's the great saphenous vein. And that is in opposition to the small saphenous vein, which is no longer the lesser saphenous vein. So if you at least come away today with those, you'll sound educated when you go into particular forum, when we go out and talk about things. The small saphenous is not lesser than the great. It's of equal importance, so I think it had a little inferiority complex there. But those are things out there that have been changed, and hopefully I pretty much always say the great saphenous vein, and every transcriptionist puts in the greater saphenous vein, and on occasion I catch it and sometimes I don't, but just in general I do know what the correct one is. Anyone who's done any peripheral vascular surgery open, which doesn't happen as much anymore, but we talk about we harvest the saphenous vein and we will either reverse it, or if you leave it in situ or non-reversed, you have a system of valves in there. And this is the one that ends up being the problem in a lot of these different cases. They're very thin, they're very fine, they're supposed to meet in the middle like it shows over here, all right, but in different pathologic processes for different reasons, they do not, all right. If anyone's done a bypass, and where's Jason? We did a trauma bypass where I reversed it and I used a valvulotome to lyse the valves, but it was incomplete, and that thrombosed that graft within 48 hours. So they are, when they work, they do a good job, even to arterial pressure 180 or 200. So normal function when you're standing here, if you put an IV at the bottom of your foot and you're going to measure pressure, you're going to have a high pressure. You're just standing there. When you walk, your calf muscle is your second heart. And what that does is it propels the blood back up towards your heart so that your pressure will go down. All right, so if you think about it, the gastroc and the soleus, they have a lot of capacitance veins. And so in a normal state, when you're relaxed, you will dump some cardiac output into there. You'll have a blood volume in there. And then when you need it, or you get up or you move, you start exercising, your calf muscle will compress and it will propel all that blood back up towards the heart because now you need it. You're doing something active. All right. In there is a system of valves that when you're resting, there is some sort of forward propagation from just arterial flow pushing it through, but this is the second part to get it up against gravity. And so you have from the superficial going through the perforators, blood going through here, some blood that's going up through here, but once it gets up, it does not go backwards in a competent valve. And then you have your calf muscle contract, and what that will do is keep pushing it up further towards the head, but should not allow it to go back out towards the superficial system or back down towards the leg. Now, mind you, we weren't really meant to kind of sit here or stand, sit at a computer for 8 to 12 hours a day, stand in the OR for 5 to 6 hours a day. We were meant to sort of get up, spurt, kill the woolly mammoth, come back and lay down by the campfire and get our legs up. So we're really asking our bodies to do something it wasn't designed for. I think that sort of ends up being a lot of the problem that we have nowadays. There are different ways that you can quantitatively measure this. There's a machine, it's air plasmography. You can do an APG. It's very cumbersome. It's not reimbursed to anything special, and other than the lab that I trained in, I don't think a lot of places are really actually using this to do a lot, but having just recertified in vascular surgery, there was 8 questions on this. So if you plan on getting to vascular, you're going to have to learn this little algorithm here. But they basically, there's different ways. They'll put an IV and they'll measure the volume. Well, for the APG, they actually put a cuff on around the leg. And so if you have your leg up elevated, your volume will be quite low. When you stand up, the slope of this curve can be indicative of if you have valvular reflux. So if it rapidly, the slope is quite steep, then you're rapidly filling up because your valves are not competent. It's just sort of flushing. Gravity's pulling it back down. All right, if you do a tippy toe in C, you have a little bit of an ejection fraction. And so for here in C and D, where you do 10 tippy toes, if you have obstructive process, you will not be able to take that volume down because you're going against a central obstruction. And so you won't have the same sort of sharp peak down through here. It'll only stay up to this part right here. And that has implications on venous hypertension and things like that from different pathologic diseases. So a CEAP classification for chronic venous disorders was developed in 1994 by an international ad hoc committee from the American Venous Forum, endorsed by Society of Vascular Surgery and incorporated into reporting standards for venous disease in 1995. And if anyone's done clinic with me, I usually will give somebody in my notes a CEAP classification. I'm not actually doing a whole CEAP. I'm usually doing just the C part of it usually, because again, a lot of times I don't know the etiology of it or the pathophysiology, but I kind of give them a C classification. I'll show you here in a second. That's sort of important as well, just so I can compare, like, why am I doing a lot of my ablations? Is it just for 40-year-old housewives that their legs get a little throbby, or am I treating patients with advanced venous disease? So it's a way for me to sort of follow them, but it's also a way the insurance companies, Blue Cross Blue Shield has a little thing in there. If you have a C 3, 4, 5, or 6, then you can automatically, with an ultrasound that has reflux, you can automatically just go straight to an ablation. You do not have to do 3 months of conservative therapy. So I try to be pretty meticulous about putting this in my notes or my operative notes or whatever so that I can kind of follow them. So for your clinical part, it goes through, once you get again to C3, that's where it's not really just sort of a fluffy, I can get this done at my little strip mall injection sclerotherapy. This is advanced venous disease. So when you start getting to C3, which is edema, C4, you start getting skin changes. C5, you get a healed ulcer, and C6 is an active venous ulcer. So the lipodermatosclerosis, I showed the pictures where it's real dark. People call it, the gator distribution, bunch of, again, different names for that. The atrophy blanche is where the skin has actually formed a white stellate scar, where they've had ulcers, or it's just basically the skin is so scarred it's just a white sclerotic area. All right, for the anatomy, you usually want to describe where this is occurring at, where you have the problems. And so it's again broken into the different areas, the deep, the superficial, and the perforators. So if you have an occlusive thrombus here in the deep system, the veins will start draining. It'll go out the wrong way in the perforators, and it'll sort of overload the superficial system. So usually our lab now, when you're looking for this, you want a lab that's very experienced, so they will look for deep reflux, which is anything over a second. They'll look for superficial reflux, which is anything over half a second, and they'll look for your perforators having abnormalities to them. And it's only been in the last year that I got here that I've convinced the lab they need to start doing, instead of gross or moderate, which are sort of generic terms with no quantitative areas to it, now we'll say anything significant, because that's what the insurance companies say significance is, and that's what the literature, that's based off of literature saying what significant reflux is. I have some slides showing that in a little bit. So again, the etiology, we talked about here, the normal vein, those valves are not going to let the blood go backwards. It can be a dilated vein, which is about 70% of sort of the advanced venous disease. What we see is the veins are dilated from a variety of different reasons. The family history, pregnancy, standing, obesity, there's a bunch of different reasons why they'll have that. Or they can be a damaged valve from, they've had a DVT, it's recanalized, so it's not obstructive, but those valves are now damaged, and they can no longer meet, they can't go up in the middle and meet and prevent that blood from going backwards. So if you think of the venous pathophysiology, one of my VA colleagues is here. Think of the government. Now that I'm part of it, I guess I can routinely say this, but it's incompetence and obstruction. All right, so if you... We're trying to work on the incompetence part and obstruction. But anyway, they're non-functioning valves like I just showed. So it can be primary valvular. People are congenitally born that way. I have a few really early teenage girls in my clinic that will come in, and they've not been pregnant. They're not overweight. They're just sort of born floppier than some. Secondary valvular, they've had 5 different pregnancies. The progesterone, which allows the abdominal wall to relax during pregnancy, also affects the venous wall function. And so that's why it's very associated with menstrual cycles. People will be able to tell they're going to start their menstruation just because of the extra progesterone, and then they feel it in the vein wall relaxes, it becomes engorged, and they become symptomatic from it. So there's different ones there. And then, again, the DVT scarring, like I showed you before. And then obstruction. So it doesn't actually necessarily have to be an obstructive DVT. There can be outflow obstruction, so pelvic masses or congestive heart failure. sort of a forward flow type of thing can cause some of that pathology as well. All right, so we're going to switch now and start talking a little bit about these different pathologic processes, staying with the acute and starting with the superficial. It's funny because this was also on my recertification boards. There's like 4 questions on it. I have to say I missed a couple of them when I was doing the pretest. They estimate about 125,000 cases per year. Again, this is a great underestimation. I think a lot of this does not get reported or added in or whatnot. If it's something that's really awful in the hospital, people can get a septic cord and they have to go to the OR. I think that's captured. Or if they show up to their PCP and they code it correctly, then that's captured. But for a lot of it, I think goes unrecognized. And I'll see people in clinic and it's very firm and hard and inflamed. And I'm like, did you see anybody about this? And they're like, no, that's been there for a couple weeks or a couple months. So I think it can be greatly underestimated. You will have acutely some erythema, some tenderness, a palpable cord, or in the varices, you can actually feel sort of the bubble distribution where they have a bunch of varices. It's really an increased risk from hypercoagulable state. And then especially migratory SVTs associated with occult malignancy, sometimes up to 7 years before the cancer is diagnosed. People sort of have this, they had a phlebitis here and phlebitis there, and they got treated with nonsteroidals and nothing else. So it's something to think about when a patient comes in with multiple phlebitis episodes. Risk factors include varicose veins, which is associated with 60% of them, greater than 60 years old, obesity, tobacco use, and then if they've had a history of DVT, they're sort of already scarred. Trauma, most common really source is the IV cannula that comes in again where they get the phlebitis and scar off the antecubital. Extension to DVT, which is interesting. If you have varicose veins, 3 to 20% will extend into a deep venous thrombosis. If you have no varicose veins, a higher number, 44 to 60%, will extend into a DVT. And that's, again, probably going with the fact that if you don't have the varicose veins, it's more of a prothrombotic or an occult malignancy or some hypercoagulable type of reason what's going on, and those are the patients that will progress. So the guidelines for the upper extremity, it's kind of the standard warm compress, nonsteroidals. You move the IV. Most people probably give antibiotics, although, again, there may not be a lot of literature to totally support that, but it's what we usually do. Surgical excision of the entire vein. I have to say I've done at least 4 or 5 of these out here in San Antonio since I've been here, whereas in the previous 6 years I think I did maybe 2 or 3 in the prisoners. But I've seen a lot of people out here with like IV drug abuse, popping, I guess, whatever it is. But anyway, I've done more out here than I have in a lot of years previously. And it's a pretty morbid operation. You really have to just fillet them open the entire way. The vein wall is very thick, bleeds a lot, and you technically should leave them open. Ideally, if you do it, you're supposed to go to, up to like the delta petrol groove or where it joins the big axial vein. Sometimes I try to get away with not doing all that if I can, but it can be a fairly morbid thing. For the lower extremity, there are guidelines. If you find that the SVT is within 1 centimeter of the junction, you can do either a ligation of the junction with or without stripping, which had a 2B evidence of basically moderate quality, or anticoagulation with warfarin. If it was over 1 centimeter from the junction or tributary, you could do the standard ambulation, warm compress, nonsteroidals, or if you keep getting it in that area, you can do surgical excision. And this was the question that was on the recertification. They had someone who had a great saphenous that was within 1 centimeter of the junction, and the answer was to do anticoagulation. So I have to say, if patients come into clinic and it's just a simple phlebitis that's pretty early on, I actually am usually very liberal about numbing them up and sort of popping it like a butt pus. You just put a little local in, you get a 11 blade, you pop it, and you extract the thrombus. They will be very grateful because that's a large bulk, especially if it was in a varicose vein, pre-existing vein. It's just very inflammatory. There's a large burden there, and they're very painful. And especially, too, after I ablate people in the OR, and they've been feeding some big branch varices, they no longer sort of have that flow, and so they tend to want to thrombose. And the insurance companies won't pay for you to do a phlebectomy at the same time. So what usually happens is they will thrombose them and get a pretty bad phlebitis. So I usually bring them in clinic. And I had one lady, we numbed her up, did it, and it literally shot out and like hit my thing and like ran down my face, my glasses. And I was like, wow, that's some venous hypertension. But and she was just immediately like she'd given birth or something. She's like, oh my God, it feels so good. So if you see him, take a look at it, even in the ear. I'm serious. She was very happy. She was a sergeant or something. Like she was a stout, not a stout lady, but a lady that had a lot of tolerance to pain. All right. So now we're going to switch and go a little bit deeper. The annual incidence of venous thromboembolism in the U.S. It's a little bit older data. It's from 2005. I saw some recent ones that said up to 2 million people were having DVT annually. I'm sure as we've all become more aware of it, we're probably getting more scans. We'll see this go up. The thing to take away from this slide here is, say if you have 900,000 people have a DVT that's diagnosed annually, you're going to have 500 that may have a pulmonary embolism, no P, 400. But if you look at it, 2/3 of people are going to be living with this DVT, 1/3 are dead. That's pretty significant. And still, if you look at all these different, some of the trials at the bottom I talked about, when they randomized people into getting thrombolytics and whatnot, people died of fatal PE before they even got them in the randomized trial part of it. And so it's pretty evident out there that this happens a lot. But if you look at the 2/3 that are living, 1/3 they're going to come up with the Post-Thrombotic Syndrome. Okay, so it used to be thought of like when I was going through training, it was like, oh, they might have some leg swelling or some problems down the road. I'm going to show you some slides later where it actually happens pretty quickly. So what are the current treatments for DVT? Anticoagulation, I think, is what most people are really familiar with the most. And this is one of the problems with this. Many specialties we all dabble in it. We all kind of know about it. Hematology probably follows the chest guidelines the most, but we all know that treatment for DVT is anticoagulation. If they have a contraindication, they have a failure, they'll get a vena cava filter, which do not treat the problem of the underlying blood clot. They do not prevent post-phlebitic syndrome. They do not do anything but just prevent, hopefully, the pulmonary embolism. And they also do have their own known side effects, which is a 5 to 20% chance of cable thrombosis over time. So they're not free. I think they've gotten so easy and they're so slim and easy to put in. It's become very let's just put a filter in them. But most retrieval rates, we were doing it a lot for trauma in Galveston. We used to call it triples. We'd trach them, peg them, and then Vascular would come in and put the filter in. We had about a 20% retrieval rate. Only because of the ones we were finding, we were getting about 90% of them out, but only 20% of people we actually found or caught or came back to clinic or whatnot. So there's a bunch of young women out there, childbearing ages, that probably actually lived through their traumas that have an infrarenal IVC filter. So you got to be real careful on some of these. There's the open mechanical thrombectomy, which I did get to see quite a few of in my fellowship. Systemic thrombolysis, that's mostly for PE. Most protocols are somewhere between, they'll start out with 15 of TPA intravenous, and then they'll give up to 100 milligrams of TPA, which just blows my mind. It's a lot of TPA. But it's just given through an IV and you let circulate. But if you really suspect someone, if they have a sudden cardiac arrest from a PE, you need to give them the thrombolytic. Of course, most of ours have major contraindications to that, and we can't do it. There's catheter-directed thrombolysis. It had a lot of energy, and people were very excited about it in the late 90s. And then they had a lot of bleeding complications, intracranial hemorrhages. And I think a lot of the hematologists really are sort of hanging on to this. They saw the young mom who came in with postpartum DVT and then had the thrombolysis, had a head bleed and died. And I saw one during fellowship. It's awful. But so some of the newer things nowadays, what we're trying to promote, are to take away some of that risk with the just catheter-directed thrombolysis over a long term, and we're trying to get them done quicker with smaller doses. And that's where the pharmacomechanical thrombolysis comes in. So the American College of Chest Physicians had their recent update in 2008, and I'm sure I don't know if you guys are all familiar with it. There's actually a link to get a free copy at dvtrevolution.org. Otherwise, you can pay for it. It's like they have a big book, and then they have like a little primer book. But it's evidence-based pharmacomechanical thrombolysis in select patients with extensive acute proximal DVT we suggest that catheter-directed thrombolysis may be used. Okay, this is in difference to the previous chest guideline where they did not recommend it. Okay, and so most of the people who are interested in venous thrombolysis found this as like this huge revelation. It's funny, there wasn't even actually a lot of data published in between the previous one and this one where they sort of changed their mind and they said it may be considered. And then they suggested pharmacomechanical thrombolysis with the inclusion of a thrombus fragmentation and or aspiration in preference to catheter-directed thrombolysis alone. Okay, so that was sort of just really kind of going out there for them and trying to get the word out in hematology to buy on it because, quite frankly, in most institutions in private practice, the hematologists rule the DVTs. When I was in Galveston, we had the vascular lab, so when I wanted to do anything with DVT, the vascular lab would just call me, and I would go up and call medicine who really had no interest in it at all anyway. But here, most of the private practice hematologists will direct what that patient has, and most of them really aren't that into this. So I've spent a lot of time going to different ERs and hematology groups trying to get them to buy into some of this. So the patient selection criteria for thrombolytic treatment, you really want a functional patient with a symptomatic iliofemoral DVT. Most of the things out there right now, so if you think of it's like aortic, occlusive disease, if you break it up into zones, you have caval, iliac type of problems, you have femoral popliteal, and then you have tibial and gastroc issues. You're really looking for the more proximal symptomatic patients, and they need to be functional. Again, this is to prevent long-term sequelae of having a DVT. You want to make sure they have a long-term sequelae, just like carotids. You want to make sure, or aneurysm repair, you want to make sure you're picking up people that have a chance that they're going to live that long. So if they have, stage 4 prostate cancer, probably not so much. Extensive thrombus burden and or venous ischemia, extension in the IVC or IVC thrombosis after filter placement, phlegmasia, if they have a high risk of fatal PE. So I know we've gotten some people being more interested in patients who had lung transplants. They wanted to make sure that they went on with that. Propagation of DVT despite conventional therapy, or then underlying anatomic abnormalities, which are the May-Thurner and thoracic outlet syndromes. All right, and phlegmasia, when you see it, it's pretty amazing. Clear up to, I had a hard time finding some of the elba and the cerula, which is the big blue leg, and then the white leg, where it's gotten so much venous congestion, you've actually cut off their arterial circulation. So the pressure is higher than, their systemic pressure of 150. I did see one of those in fellowship for a guy with metastatic prostate cancer. That was pretty impressive. And then some venous gangrene down here. This is a lady, her husband was actually faculty here, and she had lung cancer, and she had a port placed in, like a private pulmonologist. They just place them in their office nowadays, I guess. They have a mobile C-arm. And so she had a port placed and came in with arm swelling, and they said, oh, it's okay, and I got a scan and said it was DVT. Put an anticoagulation. She was having more arm swelling. Long and short is she came to the hospital, and they admitted her, where on a Thursday night, one of my partners just said, got the consult, and then the next morning said, hey, can you go look at this? And I'm like, yeah, sure. And I just happened to have a case cancel, or I probably wouldn't have seen her for another couple hours or the next morning, DVT, whatever, right? And I saw her hand. I was like, oh, my God, this lady needs to go to the OR emergently. And she actually did lose the tips of her fingers, but I was able to at least save her arm and save her hand. And I did open thrombectomy on this. I didn't feel like I had enough time to really get a venous, mechanical, get in and take the time to do that. Excuse me. For an open venous thrombectomy, they're actually interesting. So if someone has a major contraindication of getting a lot of venous thrombolysis, but their leg is immediately threatened, you basically do an exposure on the femoral. You do an exposure on one of the posterior tibials. And so you have to go against the valves. You can't do like an arterial where you just float the fogarty down and pull it up. You will have valves there to prevent that. So you sort of have to go fishing. You go up, you catch it, you bring it down, and then you bring your balloon back up with the valves, hoping to not destroy them, but get some of that clot burden out. That's interesting. And then at the end, you usually do an AV fistula to help maintain high flow through all that. Then you have to come back and close that off at some point. So pharmacomechanical thrombolysis, it infuses and disperses thrombolytic agents to dissolve, remove thrombus, and restore vessel patency. It's more rapid, ideally. Of course, most of the companies say you can do it in one shot for like 15 minutes. I have not found that at all. They're like, oh, you can do it real quickly. But it does usually have rapid resolution of symptoms. You can use a lower lytic dose. Most of the ones, I can use 10 milligrams of TPA, as opposed to some of them when they were doing this catheter-directed, they were using 30 and 40. And so they've shown as you start using more TPA, your chance of having complications increases. So you try to keep it as low as possible. The single setting, I've not found that at all. Although we had one patient at the VA, he came in for a colonoscopy and went out by 10, and then at 12 o'clock came back to the ER with his leg massively swollen, and they took him down and thrombolysed him, and he had a huge iliofemoral DVT and literally got the whole thing out and clear within 3 o'clock in the afternoon. So no incompetence or obstruction there. And so it can happen if you catch them right away. It can very easy just to suck it out. Disadvantages, again, bleeding, and then you can have a PE from clot fragmentation. And then depending on how long it's there is sort of what you will find when you go in with these different things. And so some of the stuff I've removed has been, very nice, just fresh clot that you'd scoop out of a wound, a little bit more formed clot for the subacute. And then what I usually get is this chronic white frothy stuff that comes out, which looks really weird when you pull it out of a vein. We have these big, it goes through a 12 French catheter, a 12 French sheath, and it's a suction catheter. It's almost just like the suction that you put up to the wall, and you just start sucking out and trying to pull out anything that you can. So there's about 3 devices that are pretty routinely on the market. Unfortunately, none of them are sort of single. It would be nice if you could have the ability to kind of use each one of them, but just from a cost perspective, you don't. One of the ones I've used the most that I like has a isolated lysis. So you put the catheter through, and surprisingly, even for chronic occlusions, these catheters will go through. You put it through, it has 2 balloons, so you isolate where you infuse this TPA, and it's got this little tail that shakes, and it basically agitates. You put the TPA, it agitates it into there, and then you try to suction it out. The ECOS, which is an ultrasound, it infuses the TPA, so it injects it into this theoretically the old clot. It's better for that, so it can get the TPA into cross-link with the cross-link fibers and try to get them to dissolve. And then the angiojet, I'm not sure if anyone ever used it. We used to use it a lot for for dialysis clots and whatnot. And it has a power pulse where you jet the TPA into there, you let it dwell for a certain period of time, and then you try to suck it out. Those are the 3 main ones on the market. So this was a young boy who was 19 years old, whose dad was a lawyer, who was in college and was studying and came in with leg swelling. And it's been going on for about 2 or 3 weeks till he finally got down to, I guess he got to Sidemen, who gave him to me. And we went ahead, and so what we usually do is we have people, you have to put them on their stomach, and then ultrasound entry the popliteal vein, or I try to do the small saphenous vein, so that way I can put a 10 French sheath in and not worry about compressing it in the popliteal space. And then you take your pictures. So on the initial cavogram or venogram here, you can see his pelvis and his femur. You can see sort of all this rattiness going through here. And so I worked on it, used a bunch of so we started this on Friday and came back on Saturday and did a follow-up. And I was so excited when I started seeing all of this in through here. I'm like, oh, I got all that open. It looks kind of crummy up here. And I'd had a view crossed over. I knew his other iliac was open. He has his filter in place. And so I went in and tried to balloon angioplasty all of that whole area there. I'm like, that's still pretty down. Let me see if I can balloon that and get a little bit more out, sort of macerate the clot open. And then when I did, I took my next picture, and there I just saw that giant old clot cast from his bifurcation just floating in his IVC. And then I kind of just panicked. No, kind of decided, I was like, that's a problem. So we ended up thrombolysing him all day Saturday and all day Sunday, and ultimately got it open, but it certainly took a lot of work. So this was not an acute, but it was more of a chronic thing, and he had an acute exacerbation in another area. Ultimately, though, his leg here, he's the classic. Their legs will externally rotate. They're so swollen and heavy, they can't really hold it straight, and so the classic is their leg is externally rotated and swollen. And it was big, and he could barely walk on it. He was wearing crutches. And then ultimately we were able to get his legs back down to a normal size. And he's doing quite well. He ended up actually having venous stents and whatnot, but he is a homozygous factor V, and that was sort of his predisposing risk factor. So I almost said to the mom, really, I didn't know they lived. But anyway, so I was like, oh my God, I never had one of those before. I can't believe I thrombolysed him. But I did, and he's doing pretty well now. He's about 8 months out. This is a woman, she was a nursing student who was sitting cross-legged, studying for a nursing test, and had groin pain. And so she came in, and they did an ultrasound and diagnosed her with DVT. And she finally got to me. It was about 6 weeks later, and I made plans to do some thrombolysis on her. She was like a small kid, too, like 3 years old or something. And so she came in, and she was actually menstruating, and so I had to put it off even another week. So she was really kind of outside the bounds of when people really want to try to do these types of things. But we went ahead, and she understood enough about this that she wanted to try. And some of my initial venograms, so this is the femur here going up. You can see sort of all this loosened clot in through here, and then see it gets real narrow, and you start seeing these collateral veins. And then here at the pelvic brim, again, she is supine. This is her right leg. See all this in through here? And then there's like a massive net of collaterals. And then you see sort of a cast in through here. All right, so that's probably the deep femoral vein there. That's the common femoral. And then it just stops. There's nothing. There's no forward flow going into her pelvis at all. All right, and so this is sort of another view of that where there's just nothing going in. So I was able to get a wire across it, and we use intravascular ultrasound to confirm that you're in the right, you're not retroperitoneal or in the soft tissue or whatnot, especially if you're going to give the thrombolysis. So we'll use intravascular ultrasound to confirm you're in the right spot. And then I also had a filter in her, and I had a triple lumen on the other side, so I could also see where the bifurcation was. And after about 8 hours, I brought her back and did this, and I was very excited. I was like, wow, I recruited all these collaterals, and it looks really good, and it's draining across her uterus and whatnot. And then I came back the next day, and I'd actually lost all of that. It was back to where it was. So I did some more with this mechanical device, sort of opening it up, and finally got a channel open on her. Now, unfortunately, this was pretty early in my experience. I didn't know to call and get bigger stents, so I wish I would have put a little bit bigger stents in her, but I was ultimately able to get that open. I just saw her recently, and she's been doing fine. I'm stent scanning her. She's very compliant. She wears her compression hose, and she's doing quite well. I came back and took the filter out at 6 months was the completion of her coagulation. And I shot down the stents, and that's doing pretty good. So her legs are very compensated. She doesn't have any morbidity at this point from that. Of course, now she wants to try to get pregnant. I have no idea what to tell her. I don't know how these stents would react with a gravid uterus. So we'll see how that goes. But she's 3 years out and doing quite well. Here's some other views where I talk about, so this is what you want to get, is sort of this big dilated vein with this intraluminal clot. And what you do is you put these little devices up, and you can suck it out, and you get the whole vein open. When you look at leg diameter reduction, it's pretty amazing how their legs will go down overnight. All right, so you've got the big swollen leg, the popliteal entry, and you'll compare them. And usually what I'll do is I'll wrap them the next day. I'll wrap them overnight and keep them in bed with their leg up. And I had one guy, his thigh went down over 20 centimeters overnight. All right, so it's a huge outflow obstruction that's been removed, and they feel a lot better, and immediately and then long term. Of interest, May-Thurner, you may see that may be in the general surgery boards. That's an anatomic, it can be a normal variant, quite frankly, but in some it becomes pathologic, where the iliac artery is sort of sitting on the iliac vein, and it does a compression on it, sort of pancakes it. They may comment in a lot of CAT scans that it's pancaked, and that's a venogram kind of showing it. A lot of these people on the left side, we are finding, when they have the iliofemoral DVT, that they had something like that going in and doing a venous stent and trying to get that open for them. So if you look at the morbidity of the post-thrombotic syndrome, it's really reduced quality of life. And it's related to the severity of the DVT. Again, especially if it's more proximal, it's iliofemoral, it's predictive of this morbidity. If it's treated with anticoagulation alone, 90% of people will have ambulatory venous hypertension, 40% will have venous claudication, and 15% will have ulceration within 5 years. All right, so Venous claudication is where people start to walk and then they get sharp, searing pain apparently in their buttocks and they can't go on very far. Most vascular surgeons poo-poo. I think a lot of people have it. I think if we looked at it objectively, we'd see a lot more patients actually really do have it when they have the iliofemoral DVT. And it's not so much that they just get tired, their legs are heavy, and they don't go very far. And so it's very easy, it's insidious, it's easy to miss. So if you have a combination of venous obstruction and valvular incompetence, that's when the patients have the most severe post-thrombotic problems. All right, here's a nice picture of an obstructive DVT. If you look at this venogram, it doesn't seem that bad. I mean, you see some intraluminal filling defects, but you see contrast going the whole way up, and the radiologist didn't read it as grossly abnormal. It just said, evidence of old DVT with some intraluminal, but vessel patency, it's open and draining well. But then the post-mortem on this patient, they actually got it. You can see the luminal obstruction is fairly large. If you look at different series that come out with a post-thrombotic syndrome, and they have different years of follow-up, again, when I was going through training, most people said, oh, it's 20 years down the road, they might have an issue. But if you start looking at and objectively follow these patients, within 1 year, up to 20%, 2 years, 23, 5 years, 28. Now, this study at 5 years found almost half, and this study at 1 year found 27% over a quarter. So those are some pretty impressive numbers for patients if you start looking. So not necessarily just they come up with venous ulceration, but they have heaviness, aching, throbbing, things like that. And if you look at it, the 75% of the cost of treating DVT is related to the post-thrombotic syndrome. So they come in, they have anticoagulation for the acute DVT, that's not so costly. But when they, miss work, or they have venous ulcers, or they come in and have repeated cellulitis, that is the cost that's associated with it, and then lost patient days. So the relationship between ambulatory venous pressure and the incidence of venous ulceration is also there as well. So for patients, once you get up to over 80 millimeters of mercury, when you're measuring, in the days when they used to put IVs in and measure them, the incidence of venous ulceration is up to 80%. So if you have someone whose ambulatory venous hypertension is 80, and then you put them in a 40 millimeter compression hose and get them down to here, you can see where they start healing and their incidence of venous ulceration. Now, I wear a 30 to 40 millimeter compression hose sometimes. It is not comfortable, and it is not easy to get on. This is not an easy pill to take for people. For the Torpedo Trial, there's not a lot of prospective randomized trials for this, okay? And that's been sort of the hard part for the hematologists who are oncologists who are used to big, NCI type of studies where they have a lot of 1A evidence. The Torpedo Trial came out last year in the Catheter and Cardiovascular Interventions Journal. Not exactly high impact, but it's at least a start. They compared anticoagulation to anticoagulation plus percutaneous endovenous intervention. Again, a lot of these are industry-sponsored, which, of course, makes it tainted and scarlet letter type of thing, but it's at least getting people into the mindset. They had some primary endpoints, very short, for 6 months, development of post-thrombotic syndrome and recurrent DVT, and they also had a bunch of secondary endpoints. For the primary endpoints, when they were looking at some of these things, if you look at the anticoagulation, which they had 88, and then the percutaneous 81, recurrent DVT, those are backwards. There was a lot more in the anticoagulation trial as opposed to the intervention trial, which became significant. Actually, I switched all of those, didn't I? All right. So anyway, there was statistically significant fewer recurrent DVTs and post-thrombotic syndromes in the patients that had had an intervention. So it's at least got people interested in looking at this, and hopefully they'll start coming out with some more long-term than 6-month data and going on and trying to see what it's helpful for. And if you look at their quality of life, there's a bunch of venous Aberdeen scores, and there's a venous quality. There's about 4 or 5 different scoring systems out there where you can give patients and ask them about their quality of life, and they talk about it. It significantly impairs a patient's quality of life, and it's considered a chronic medical condition similar to severe arthritis, COPD, angina, congestive heart failure. Like, it significantly inhibits what they can do. If you take the other thing, other than not calling it the superficial femoral vein, the other thing to bring out of this today is that the early use of medical grade compression hose, 30 to 40, reduces the risk of this by 50%. Problem is, I bet you maybe 2% of people actually get to the people like me who say, oh my God, you need to be in medical grade compression hose. This is the prescription. This is where you go get them. By the way, it's going to cost you $150 out of your pocket, and it's painful. So the problem is that only the few people that really understand this or get it preached to them how important it is really get the appropriate care. But it's significant, reduction for people who wear it for 2 years. All right? So 30 to 40 for 2 years, ideally thigh-high or pantyhose. But I think the area most at risk is the calf. So if I can convince them even to do knee highs for 2 years at 30 to 40, then I think we've at least given them some service or protection down the line. So if we look at chronic venous disease, I think you've all seen this through clinics. You rotated through vascular, aching, throbbing, cramping, heaviness, tired, dry skin, edema, throbbing with standing, discoloration, burning, numbness. The association with restless leg syndrome. A lot of studies come out now when you ablate the superficial reflux, their restless leg will go away. The disability, again, sometimes it's cosmetic, mild, moderate, and then chronic venous up to ulceration. So, again, the quality of life is decreased. When you evaluate it, it's very easy to do with reflux with an ultrasound. We don't need a lot of ascending and descending venograms anymore, so we've kept it to pretty minimally invasive. And what they'll do is they'll put a Doppler probe. They'll have a patient standing with gravity there. They'll put a Doppler probe at the area, and what they're looking for is negative flow. So if you increase blood flow through the vein, it should, for about half a second, go reverse, and then it should stop, just like this one here. Whereas you can see here, the blood just keeps going backwards, and that's considered significant reflux. Treatment options, conservative. I think for years, most of the primaries have been like, oh, it's veins, don't worry about it. But you can see here, someone with primary, they've got this big, massively juicy, wonderful, dilated anterolateral vein. And I love it. Phlegmasia is my favorite operation in the world. And then you go in and you've got this lipodynamic skin changes. Like, that's not cosmetic anymore. So there are things to do for that. There's ablation and laser, stripping. We don't really call them staph phlebectomies anymore since we're trying to get people in. We call them mini or ambulatory phlebectomies to make it sound a little better. Then there's advanced venous surgery, too. There's valve translocations, implications. There's venous bypasses. Those are the types of things that I did in my fellowship that are fun to do. Conservative therapy or medical-grade compression hose, you can really back down to 20-30, and that's my standard sort of every day-to-day hose I usually wear. Exercise, healthy weight and diet, avoidance of excess heat, which, of course, in Texas is pretty much not available. If you look at the strengths, again, it sort of goes through. Anything below 20, you can get over the counter. So a lot of patients are getting them at the HEB. They'll usually have them. But once you get 20 to 30, you're really supposed to have a good pulse exam by a physician before it is prescribed to you, and that's a medical grade. For lymphedema, it can go up to 50 to 60. I mean, awful to put on and wear. There are some alternatives now. There are some ulcer cares where you have an inner sleeve that's about 10 to 20, and then an outer, which is about 20. And so combined, you get about 40. Much more palatable to have, the 80-year-old wife put on the 80-year-old man with their, rheumatoid arthritis and her fingers turned sideways. It's a little bit easier. You see some things, you're just like, oh, God, this is never going to work for them. But there's the Ferro wraps or the Circ aids. Those are available and out there as well. At least it's something. A lot of my patients with congestive heart failure with those big legs that don't move, especially the VA and their scooters, I try to get them into something like this because what happens is a lot of those don't even have venous problems. It's they never use their legs. It's dependent all the time. They sleep in a recliner, and so it just leaches out in a lymphedema. And so I at least get them in something like that. We stop the number of admissions for recurrent cellulitis. RFA, and there's a laser, basically the same type of thing. Studies have shown that if you have superficial reflux, as long as you don't have a complete deep obstruction, you can have deep reflux or, non-occlusive thrombus, but when you ablate at least one of the systems that are going the wrong way, so you have 2 bad kids in class that are destroying the class, you get one of the kids out of the class, at least the rest of the class will usually do better. And that's sort of the theory behind some of this. It's not helping any. That vein is not really a channel. It's deteriorates to the whole system by going negative. So what you do is the vein stays in there, you don't strip it, you just ablate it down to a cord with 120 Celsius of heat. Under local, in your office with no sedation. And so after that post-ablation, if they have the big dilated varices, those will usually, they're not pressurized anymore, so they will flatten down. It can be a standalone procedure 50% of the time. All right, so that's why a lot of insurance companies won't actually pay for the phlebectomy at the same time, because half the time you don't need it. You have to wait 90 days. If you look at symptom relief, 5-year registry results, usually again industry sponsored, but pre-treatment, pain, fatigue, and edema, it does very well far out. And considering the fact what it used to be to strip and have to go to sleep, when you can do most of these within, they call it lunchbox surgery, where they come in and get it done in half an hour, you see some long-term benefits. And I do people with the VA, 80 years old, on Coumadin, aortic stenosis, congestive heart failure, can't lay flat. The anesthesiologists don't necessarily like it, but, they've got a big venous ulcer, and it's just like, give me, 17 minutes to ablate this vein, and I'm going to make a world difference. Just keep them mildly happy with, like, one of Versed. And we've kind of gotten a whole system now where they're not as scared of these patients, because they do fine. They do. Unless you inject the lidocaine with that be intravascular, then they get a little tacky, but usually goes away very quickly. A little more chit-chat, and they're fine. For venous ulceration, you must evaluate the other potential causes. So is it arterial ulcer, diabetic, neuropathic, vasculitis, infection, neoplasm? Some of these people have had ulcers for over 15 years in these areas, so I always send them to derm to get a biopsy. The goal is to eliminate venous hypertension. That's just that nasty looking. You can even see the big bulging areas in through here. So I just take and eliminate any other vein that's there big. Again, try to get rid of it. You do local wound care. This is Dr. Unna, who started out with the Unna Boot. Now, I don't know how many of you guys, probably the old schoolers here, had Unna Boot clinic. Did y'all used to have one of them?
Yes.
Every Wednesday, Unna Boot clinic. I loved it. That's all right. I mean, I'd put on like 25 Unna Boots a day. Some nurse taught me, and like you really helped them. And they came back once a week, and they got their Unna Boot changed. With the advent of wound care centers, and we're all so busy and it's not glamorous, that's gone by. It's really a great disservice. I think a lot of people, very few people get an adequate compression with an Unna Boot nowadays. And I'll see people wrap, and instead of the nice little crisscross wraps, they go up, and it's everywhere and back down, and big, thick folds, and just not the same as it used to be, unfortunately. But there's level 1 evidence that it promotes venous healing. And when I was looking for online, I love this picture. This is a woman had posted on some blog about going to Disney and meeting, I think that's Sleeping Beauty, with her venous, with her venous Unna Boot, which is completely inappropriately applied. You can still see the lipodermatic skin sclerosis there, and her legs just like, edema swelling over the top of it. And I'm like, so anyway, just sort of a thing of how they're not really done very well anymore. If you look at the efficacy of compression, Dr. Parch is this really, really cute guy who goes around to all these meetings, and he'll wrap you. Like, he put me in a short stretch wrap with like a measurement, and I had to keep it on overnight at the meeting and come back the next day and tell him how it felt, and it's sort of annoying. I was like taking it off, and I'm like, ooh, this is awful. But this is what these people need. But there's 1A evidence and 1B evidence that this really does work for patients. There's one trial, the ESCHAR Trial. It's large, multi-center, compared superficial venous surgery, which at the time was not ablation. It was the standard stripping and steps and all that, to compression alone. Most of the patients had ulcers or healed ulcers. About 40% had deep reflux. So again, we're not doing anything for deep reflux at this point. We're just, saying you need to wear your compression hose. There are some things out there that they're trying, but nothing mainstream. It didn't significantly change ulcer healing. So unlike arterial ulcer, you hook up a new bypass, you get them more oxygenation, they heal their wound. This is different. It did not significantly help ulcer healing, although it does trend quicker, I will say. But there's a twofold reduction in the surgery arm for ulcer recurrence. So if they get them 4 times a year, they go down to 1 time a year. If they get them, once a year, they'll go to once every 3 years. As long as they still maintain some compression, you'll help them out that way. Drug therapy, it's interesting. If you've been in clinic with me, you'll see I've started giving the pentoxyphyline. You guys remember that, Trentol? It was an arterial drug in the 90s, and then we came out with cilostazol, which is Platone, and we all gave up on it. It's really resurging its head now. I hope for venous wounds. It's a grade 2B for the chest, and 400 TID was an old arterial dose. Most will actually say 800 TID, but you get a lot of stomach GI side effects. But it really has minimal interactions with a lot of other things, and it's fairly cheap. So if I can't get it for my VA patients. It's not on formulary, but on my free world, our private clinic over here, I try to get patients into some, it's an old prison thing, free world. I try to get them into some type of Trentol. Surgical treatments for venous obstruction, there are certainly some things out there. We can do palma procedures if you can't. Nowadays we recanalize them a lot, so we don't really do this. We take the contralateral great saphenous and swing it over, and so you drain that leg out this side. You can do sort of a fem-fem venous with an AV fistula on it. And there's lots of different things out there. So keep in mind that just because they have a big, fat, swollen leg, it may be worthwhile, if no one's seen them from vascular surgery, for us to take a look at them. Nowadays, some of them are minimally invasive, and so think about it in some of the patients. I know some of them are recent traumas or surgeries, and people don't think about it. But some of them we are using. I know Matt Simon did a lady who had a total knee, or no, a knee scope or something like that. He did her, I think, 6 days post-op. I was like, you're kidding me, right? They're going to bleed in her knee. But he did. He gave her like 10 of TPA. It was very isolated. Got the whole clot open. It was iliofemoral and stented her. She had a May-Thurner. So there are some times that you can go in for some and just take a look at it and see what's out there. All right. Any questions? I know you're very interested in this disease now, right?
I remember the last part of the resident's notes, and vascular surgery used to be on Surgery A. Return to clinic after I'm off service, including Dr. Pastana.
Those beautiful pictures you showed, are those actual venograms, inject dye, take pictures, or do you rely primarily on the duplex scanning?
For diagnosis, it's all just duplex, but I have been tricked now on these patients, so I get in and I think it's just a femoral DVT in their whole iliac system. So nowadays, I usually get a CAT scan with a venous phase and take a look and see what I'm getting into. I'm surprised how many patients they've thrombosed their iliac segment years ago unknowingly or didn't come to attention.
CAT scan with a venous phase. You're not injecting the vein directly.
Yeah, I will. Then once I get my information, I'll come back and inject.
If needed.
It's a popliteal entry. I don't use a venogram for diagnosis, just for treatment. Okay. So I'm already planning. I've got all my equipment there, my drugs, my reps with the machines and stuff like that.
Okay. Thanks.
Dr. Santiago, what about occult malignancy that Dr. Pounds mentioned? Is that just something to answer on test questions, or is it something that you see in your practice?
No, it's something that I see very often. I think that most there may be a lot of confounding here, that most of patients with cancer go through many outpatient procedures, diagnostic laparoscopy, there may be surgery, or maybe a port, maybe anesthetics, or long-term in the hospital. That is maybe not really the cancer, but many other factors that come to it that may increase the risk for DVT. I don't see it that often.
That's the reason I brought it up. I think I've had to answer it on more questions than actually patients I've seen with it. Dr. Dan.
So, Lori, great talk. That was by far the best talk I've ever heard on venous disease. It was excellent.
Much, right?
Most of the other ones were by residents, I'll give you that. But they didn't have the clinical experience that you bring to the table as they gave the talk. We struggle on the trauma service with venous thromboembolism prophylaxis more than treatment. And the question is, should we be more liberal or less liberal in IVC filter placement? Because with filter placement, as you point out, comes low recovery and removal rates for our temporary filters. And then maybe we're causing a bunch of venous disease, but at the same time, clinically, I can't say I've seen or heard you guys complain about a bunch of trauma patients that come back with venous stasis disease related to their filter placement from trauma 3 years ago, 5 years ago, or whatever. And so we struggle with our threshold to place IVC filters for prophylaxis in these patients. What are your thoughts?
It's definitely hard. I know, in Galveston we were very liberal at that point, but now, and so what we were doing is we were using the type of filter from Bard that did not have an out time. And so the ones that are on the market there's two that have a limited time. I think there's a third now. The one from Bard had a no out time. I mean, I took it out 1.5 years later. Yeah, and it was no problem. Problem is they're starting to see a lot more fractures, IVC penetrations with retroperitoneal bleeding. And so I think some of the people have gotten away from even using that one. I think it's a hard diagnostic dilemma for some of these patients because they get lost. They don't have funds. They do get a wound. They're stuck in a wound care clinic. They never make it to us. For some reason, it used to be we were the filter for everything, and then I guess we got too haughty or too busy, or I don't know what happened. But venous disease just went away to all these wound care clinics where they're just getting all these lotions and potions for thousands of dollars. In fact, a lot of the business that I've gotten since I've been here is WellMed, one of the podiatrists who knew me in UT. They were spending $50,000 a month on lotions and potions. And so she's looking through the books going, what are we doing this for? And they're like, venous ulceration, venous ulceration. She's like, Lori can do something about that. And so I've been getting a lot of patients just from that, these patients that are just, they get stuck out there. So I think it's hard unless we start prospectively, and that'd be a great study probably to find patients that we either diagnose with DVT and, did they get into their hose? Did they get anticoagulated? Did they get a filter? And somehow figure out how to follow them.
It's virtually impossible to get people to wear compression hose in San Antonio.
Oh, no, I can get them. I usually wear them to clinic, and so they see me, and I get them a good fit.
We've had a hard time with the 95-degree heat.
Yes.
When we tried to get our patients to do that. Thank you, Stuart.
Lori, on your venous interventions where you're doing all the techniques to relieve the obstruction, do you always put a preventive vena cava filter in there? Because it seems like to me that I would be worried that you're fragmenting that and it's going there having basically multiple PEs.
They probably are having some silent PEs. We're not catching on some of it. The current, again, there's no read a book and this is out there what to do. Most of it is we go to meetings, the American Venous Forum, and I'm like, well, what do you do? Do you put one in? And they're like, no, I don't put one in. And other people are like, oh, yeah, I always put one in. So it's been really hard to sort of come up with a clinical pathway. I personally feel much more safe with a filter in for something that's iliac, like that young kid where I broke that off. I mean, if I didn't have a filter there, I think I really would have just probably hyperventilated. I was just like, okay, it's got a filter. If I clog the filter, I can get this open with an aspiration, and so you go through your thing. So most of the time, I've been pretty good about I routinely put it in. What really has happened is I'm not putting it in. They've actually come to me from the hematologist who got the filter in, and then I'm using it.
Because this is it's a totally different, but it's an acute version of this, in that we see an occasional patient who has a major PE, who then is going to require thrombolysis, and it's always a question: should we go ahead and put a filter in while we're doing that? Because if you're going to thrombolyse this, then if you're giving systemic therapy, then they may have another PE. So it sounds like you probably lean towards having a filter in place.
Yeah, I'm pretty conservative on most arenas. So, but again, I've had filters. I was doing one retrieval on a med student who we're trying to capture it before they had the self-centering part of it, and he'd driven off seawall and going to rounds in the morning or something like that, and had been really sick, and had DVT, and so he had a filter in. And so he came back 6 months later, I was trying to get it out, and I didn't have it in this little cone that collapses it and pull it out well. And this is with portable equipment. I mean, just all the setup for wrong things. And I drug it to his, and they're like, stop, you're dragging it. And I'm stuck behind his, liver. And so I had to floss it. I had to go from below and grab it, and just by the luck of God, got this thing out. So retrieval isn't always simple. It isn't always easy. One of my old partners, Lois, took one and turned it completely sideways. By the time she was trying to get it out, it's the point here and the ends there, and completely sideways. And so there are downsides to them as well. It's not a chip shot.
Dr. Dan, you have another question? What about, do you care about us getting our patients up in a bed? I had mentors who wanted their patients supine or up walking because, you're giving them 2 venous bends. Do you think that makes any difference?
It should not. But again, getting up and walking is the best for any of this. But you may remember it used to be, I mean, I know when I started, I'm dating myself, but we used to keep people in bed with their leg up for a week on a heparin drip before you started Coumadin. And so that has changed. I know the guy I trained with, he was very much that little thing, you do an APG, we were doing studies on maximal venous outflow. And so I had to put acute DVTs, I had to put a big cup on their thigh and raise it to 300 and rapidly deflate it to see what their maximal venous outflow was with acute DVT. So that's where I kind of learned, I mean, if it was going to break off, it was going to break off. By surely doing that, I didn't break it off. I think it's very adherent, and that's the problem to the vein wall. And so the whole like, oh, I can't put SCDs on, oh, I can't put compression hose on. And a lot of the hematologists are still very adamant about that. I'm like, really, there's no literature to support that. They need to get up and walk. That's supported with literature. They need to get their hose on. That's supported. But trying to get up and move around, put compression SCDs on them, even the foot ones will theoretically promote native thrombolysis, activate your PI and promote thrombolysis. So even if they have a leg DVT, putting a foot pump on is supposed to, even if you put it on the other foot, it's supposed to actually help. Now the guy I trained with and my best friend, who's another venous person, had a big knockdown drag out at one of the American Venous Forums where they both had opposing data whether that worked or not, but it doesn't really hurt anything to put a foot pump on somebody, so why not? It may help.
All right. Thank you
Thank
very
you.
much.